Welcome to this edition of Labor Vision. I'm Bob Delaney, Executive Director of the Institute for Labor Studies and Research. Labor Vision, a production of the Institute, focuses on topics of importance to working Rhode Island families. We hope you enjoy this evening's edition.
Good evening and welcome to this edition of Labor Vision. My name is Jim Riley. I'll be your host tonight. Our guest today is Erin McDonough from the Rhode Island Disaster Medical Assistance Team. Sounds very important. Now, we've done a lot of shows over the past couple of years talking about the devastating effects of the opioid crisis, both here and all around the United States. And Erin is going to give us practical, real-world advice on what to do if at any time we are encountered with an individual who's in crisis. Welcome. It's great to have you here, and thank you for the terrific work that you and your team do.
Thanks.
I know we had you at an event the other day. We were doing a symposium on the opioid crisis in the building trades, where it's a big, big problem, as you can possibly imagine. And we were so impressed by your presentation that we've asked you to come here and talk to our many viewers today. So can you tell us about the Rhode Island Disaster Medical Assistance Team and the Naloxone and Overdose Prevention Education Program in Rhode Island?
Sure. Thanks, Jimmy, again for letting me come here and talk about this important mission of ours. So
Happy
Rhode
to have
Island, thank you. Rhode Island DMAT, or the Disaster Medical Assistance Team, is a nonprofit in Rhode Island, and our primary mission is to recruit medical health professional volunteers to prepare for and respond to public health emergencies and disasters. So in 2014, in response to the overwhelming epidemic we were seeing here in Rhode Island, we started the Naloxone and Overdose Prevention Education Program. We focused primarily at that time on training first responders on how to recognize and respond to opioid overdose, including the administration of naloxone. Since that time, we've tried to broaden our scope of practice and include more public-facing entities such as libraries, public transit, and even businesses. So thanks for letting me come on today.
Well, we're so happy to have you. Now, how prevalent is this overdose problem that we have here, and who is at the highest risk?
So the opioid epidemic has reached epidemic levels here in our state and other parts of the country. In Rhode Island and 40 other states, including Washington, D.C., opioid overdose exceeds motor vehicle accidents as the leading cause of accidental death in adults. Opioid overdose is actually the leading cause of death among Americans 50 years and younger right now. So particularly in Rhode Island, the rise in opiate abuse is completely correlated with increased sales of prescription pain medication. So as the medical field flooded the market with prescription pain medications in the late 90s, early 2000s, we started to see an increase in overdose fatalities, as well as an increase in access to treatment. So in Rhode Island in 2014, we started to see the introduction of fentanyl into our heroin supply, which really started to increase our overdose fatalities. So in 2016, we lost 332 Rhode Islanders to overdose, which is overwhelming. And over 75% of those did have fentanyl in their heroin supply. In 2017, we lost 323 Rhode Islanders to overdose. So obviously it's a huge problem.
Where is this fentanyl coming from?
So initially, when we started this program in 2014, I thought I was going to be fighting good old black tar heroin, is what I said. And so it's funny, you can look at a national map where it shows, the national standards for overdose, and it was affecting all of the country. But when you get down and you dig down into the fentanyl and the synthetic opiates, it really affected Region 1, New England, and Ohio, Region 5, that area first, the fentanyl. So what happened, and the theory behind it, is that it was actually being produced in China, shipped over to Canada, and it came down that way. So our regions were the first ones to have the fentanyl into our heroin supply. Now fentanyl, when it's made synthetically, is really, really potent. And it changed kind of the substance and the look and the feel of the heroin that we are dealing with here in Rhode Island. And it really shuts down the respiratory system and started to kill people at a higher rate and at a younger age. Yeah.
Maybe the president ought to rethink the wall in Mexico and put one up in Canada.
That's what I'm saying.
So what makes opioids dangerous, and are there some precautions we can take to reduce the risks?
Absolutely. So I think it's really important that what we try to teach, and really what I hope people start to understand and believe, is that opiate addiction is a chronic and relapsing disease, and it's characterized by a permanent change in the structure and the function of the person's brain. So susceptibility to addiction does have a strong genetic component, and when that's exposed to opiates for any reason, even as prescribed, dependence and addiction are likely to result. So with opiates, basically how I like to teach it is that, you know, you and I are really normal, right, Jimmy? We're like the most normal we've ever been.
Ask anyone.
Exactly. So when we're normal, we may get a prescription of opiates, and we take the opiates and our pain relief goes away, and we maybe feel euphoric, and when we come down, we're still normal. We do the same thing, we take our opiates, we go up, we get the pain relief, the euphoria, we come back and we're baseline to normal. Mm-hmm. Within 5 to 6 days or even a week of taking those prescription pain medications, what happens physically is that once I go up and I start to come down, I drop below normal now, and I'm in withdrawal. And what happens when someone's in withdrawal is that the primitive brain takes over, and it turns on and it says, Erin, you're gonna die unless you get some opiate in your system. The physical withdrawal symptoms are so powerful that the primitive part of my brain takes over. So people with opioid use disorder are struggling every day in order to maintain and feel like they're not going to die. So it's almost like the worst flu you've ever had, times 4 times. So this is what people are struggling with that need the opiates in order to feel like they are normal. So what happens with opiates is that, like I said, they go into the brain and they sit on the mu3 receptors of the brain. And they process feelings of euphoria, pain relief, and everything kind of melts away on that. So when we take opiates, our receptors of the brain become desensitized to their effect, the idea of tolerance. So as I take my opiates, my receptors become desensitized. I now need more opiate to cause the same effect. What makes opiates really dangerous is that my tolerance decreases very, very quickly. So even if I've been taking opiates for years, once I stop taking those opiates, those mu3 receptors within 24 to 48 hours bounce right back to babies. So if I go back to taking the same amount I was taking before, my likelihood of overdose increases. So tolerance really makes opiates dangerous. So does the effect that they have on the respiratory system. So if I'm somebody who has COPD or sleep apnea or anything that's affecting my respiratory system, say something acute like the flu or pneumonia, and I'm taking opiates, prescription or otherwise, and it's going to have effect on my respiratory system, or I could shut down. So it's very important that we recognize that if we have something going on with our respiratory system, we should be very cautious of the amount of drug we are taking.
So when you're in opiate remission, you're actually at war with your own brain.
Exactly. That's really, really a good way to put it. So basically every day our cerebral brain is the one in charge, okay? And our primitive brain turns on when we're here in that withdrawal symptoms, and we cannot control it. Great way to put it.
Mm-hmm. So what are the signs and symptoms of overdose, and how should an individual respond? So welcome back to the show, and to the magic of television, we have a new guest. This is Johnny. Here's Johnny right here. And what Erin is going to do now is very serious stuff. She's going to show us how we should respond to an individual who is experiencing an opioid overdose. Take it away.
Great, thank you. So what we talked about earlier too was that opiate overdose causes respiratory depression. So an overdose occurs when a toxic amount of drug or toxic combination overwhelms the body. Opiate overdose is characterized by inadequate breathing, okay? Inadequate breathing leads to a lack of oxygen in your body, which will lead to death if no intervention is made. So some of the signs and symptoms of an opiate overdose is definitely that respiratory depression, that struggling for breath. Whereas a regular person takes one breath every 1 to 5 seconds, somebody who's struggling to breathe, you'll hear it, takes a breath every 8 to 10 seconds, almost gurgling, snoring, okay? We call it apnea. They're definitely gonna have a decreased mental status, okay? Their fingernails and lips are going to be turning blue or gray, and that's from a lack of oxygen. If you're not getting any oxygen into your body, your extremities will start to turn blue or gray, okay? Vomiting, gurgling, snoring noises is definitely something you can see. Pinpoint pupils is a classic, okay? Classic sign, teeny, teeny, tiny pupils. So if I find somebody with all of those symptoms, my response is definitely going to be, first thing I'm going to do is I'm going to attempt arousal, right? We want to see if they can wake up. So I'm going to shout their name, Johnny. I'm going to shake them by their shoulders. I'm going to do an earlobe pressure point. I don't know if you want to try it, Jimmy. If you squeeze really, really, really hard and then you let go, this will usually try to get somebody up. We used to always classically tell you to do the sternal rub, which is knuckles up and down the chest bone here. The American Heart Association did take that out of their 2015 guidelines, so I didn't tell you to do that.
All right.
But you might want to do that. But again, okay, so we're trying to attempt arousal. If I can't wake Johnny up and I know something is wrong, the first thing that anybody is going to do is call 911. We're going to call 911 immediately. From there, we're going to tell them that someone is not breathing, okay? We're going to give them a really good description of our location, what floor you're on, where they are, and all of that. And from there, we're going to start to assess the scene. So if you come upon somebody who you're not familiar with, an overdose can look like any other medical emergency, right? We talked about respiratory breathing, lack of oxygen, blue or gray. Like, how do we know? So what I'm going to teach you guys today and tonight is how to respond to an opiate overdose. So if I know that Johnny is someone who's been struggling with opiate use, or if I see any visualization of drug use, whether it be powder on the table or any syringes around or near, or pill bottles, or somebody, his friend said, oh, we took a ton of pills before we got here, then I know I'm responding to some sort of opiate overdose or some sort of overdose. And this is how I will respond, okay? So first thing I'm going to do, again, I'm going to attempt arousal. From there, I'm going to actually check for a pulse. Now, depending on your level of training, this could be difficult for some people, but the reason we love to talk about it is because if you have a pulse, that means that your heart is still beating, okay? That's very simply it. So if I have a pulse and Johnny has a pulse, I know his heart is beating. So we have gone in this society to hands-only CPR, right? Chest compressions only. Staying alive, staying alive. Staying alive. Chest compressions only is a wonderful tool. It is a wonderful tool for cardiac issues, for someone whose heart is not beating. If I come to Johnny and he has a pulse and I start doing chest compressions only, I'm really not dealing with the problem, with the respiratory issue. So opiate overdose causes respiratory failure, right? So this individual needs naloxone and they need breath. So if you can find the pulse and you know the heart's still beating, first thing I'm going to do is I'm going to administer naloxone, put my hand under his neck. I'm going to hold this device, which comes from our Narcan nasal spray, 4 milligram, 1 ml, a really, really, really simple device that you can see. I hold it in between my pointer finger and my middle finger. You don't want to push the trigger until you're ready to shoot, which means I'm literally going to insert the device into Johnny's nostril, into my finger is touching his nostril. From there, that's when I shoot the Narcan up his nose. Now it's mucosal. So Narcan works mucosally, intranasal, through the mucus of the nose, travels through the brain, pushes the opiate off of the receptor of the brain, and allows Johnny to start breathing on his own again. Now, what makes Narcan wonderful for lay responders, too, is that it only works for opiate overdose, not for other kinds of drugs, only for heroin and opiates and Percocets. However, if there's any indication that any drug has been taken whatsoever, go ahead and administer naloxone, because there are no adverse effects to naloxone if it's administered to someone who's not overdosing on opiates. So it will do no harm, but it will help if there are opiates in there, okay? So we've come up to Johnny, we think that it's an opiate overdose, we administer our naloxone, we check for a pulse, we realize that he still has a pulse. Now Narcan takes about 2 to 4 minutes to start working, so until that time, it's really imperative that I get oxygen into this individual. So a lot of us carry some barrier devices. I always recommend that we use a barrier device when we're giving CPR. I just put this over Johnny's head, and I'm gonna make sure that we want airway, airway, airway. So when I'm teaching people about CPR and about rescue breaths, we want to make sure we use the mandible bones when we're pulling back. And we've got to get on the mandible bones, airway back, and then I give 1 breath every 5 seconds, okay? 2 to 3 minutes. If there's no improvement and rescue has still not arrived, I can go ahead and give a second dose to Johnny in that second nostril, okay? Administer the second dose, and then I would continue my assessment. If we're not sure if he has a pulse or not, what I would always recommend is to do full CPR, okay? Which is 30 chest compressions and 2 breaths, especially when we think it's an opiate overdose, just so that we're getting that oxygen into the individual in case we missed the pulse, okay? So usually what happens with the administration of naloxone, here I have a couple of different routes of administration. I did show you the new Narcan nasal spray, which is really easily available now, 4 milligram, 1 ml. I like to say it's so easy, even a glazier could do it. Remember that joke?
Oh, yes.
And I can say that because my cousin is a glazier. There's other routes of administration too. We have the intramuscular versions, which are still available. And you can get kits like this for people who are struggling with opioid use disorder. You can get a syringe and 2 vials of naloxone, which come already pre-prepared with 1 cc. And this is the older version of the intranasal naloxone that we had in use prior to the FDA-approved Narcan nasal spray here. So as you can see, it's really quite simple, 2 doses in this 1 box. And again, what makes Narcan really great, especially increasing access to it for medical responses or in your first aid kits, is that, again, there's no adverse effects if it's given to someone who's not overdosing on opiates, okay? So it's really one of the most benign drugs there is.
That was an excellent demonstration. I'm sure it was very educational for our viewers. It's hard-hitting. Incidentally, John has survived his overdose and is resting comfortably off the stage here. Now, people have been watching this and they'll say, well, I don't have this stuff. I don't have, let's assume, let's just say you're a parent and you think that your kids could possibly be involved in some activity. Let's say you're a user yourself or you know users. How do you get this stuff?
Yes.
How do you get this naloxone?
What a great question. So officials in Rhode Island realize that increasing access to naloxone is really our rescue pillar, right? We have to keep people alive so that eventually they can access the right form of treatment. And because naloxone reverses the effects of an opiate overdose, we have worked really hard to make it more accessible to people who are struggling with themselves with opioid use disorder, or like you mentioned before, a parent or a friend or a relative of someone who's struggling with opioid use disorder. So the collaborative practice agreement in Rhode Island allows individuals to walk into any large chain pharmacy and even some of the smaller ones and request naloxone, and it can be dispensed by a pharmacist without a specific prescription.
Excellent.
So you can walk into any of the large pharmacies and even maybe your smaller local one and say, I would really like to get a Narcan kit. Yeah. And what happens there is the pharmacist will ask you which type you would like, the intranasal Narcan kit or the intramuscular perhaps, and some of them still offer this older version of the 2 milligram, 2 ml.
What do you recommend?
I mean, I think just for ease of access, this Narcan nasal spray is really good. All routes of administration work, and none are better than another. So, I mean, I obviously am not making any money from Narcan, so I just always think that because without an exposed needle, I think it's a little bit safer than the intramuscular, but really, if you're trained on either of these, they both work. So they're both great. But again, if you're not really, you don't feel great about the needles, go with the intranasal spray. So again, you can just walk into your pharmacist and ask. It's covered by all insurance. All third-party payers will cover the cost of this. You may have to pay your copay. Okay, if you have one. Out of pocket, if you wanted to pay for it, if you didn't want to put it on your insurance for whatever reason, it's about $215 a kit, this version. Obviously, the intramuscular is way more affordable too, the 2 vials. It's about $25 over the counter too. And again, the pharmacist will go over it with you. Pulling this up is not all that difficult. Right. And then if you dispose of the needle safely, it's really a good version as well.
Speaking of rescue pillars, I recently read an article in a newspaper regarding the safe stations in Providence. What a wonderful, wonderful program. Tell us about it.
Sure. So I'm not the expert on it, but I am a huge proponent for getting the word out there, so I'm so glad that you brought it up. So the Providence Fire Department and Chief Kenyon of the EMS system in Providence started the safe stations, which was mirrored off of a program very similar in Nashua, New Hampshire, somewhere in New Hampshire, I believe. Basically, all 12 fire departments in Providence are open 24/7 and will accept anybody who wants to walk in and who says, I need help. So no matter what you're struggling with, what problem, what addiction you're struggling with, you can walk in and you can ask for help, and the Providence Fire Department they'll check you out and make sure you're not in any type of crisis or medical emergency that they need to take you to the hospital for. If you're cleared via EMS, they will get you in touch with Anchor Recovery. Anchor Recovery will come and meet you, or peer recovery coaches, which has really been instrumental in helping get people on the path to recovery, is a peer. So Providence Safe Stations puts you in in touch with a peer-recovery coach, and from there they get you into the right care and find the treatment when you're ready.
What a terrific program that is. Okay, so lay responders, someone who isn't a professional, like firefighters who are very professionally trained, individuals who come to your house when you're down 911. Lay responders, are they covered under the Good Samaritan law?
Absolutely. So we know that not everyone is a trained medical health professional. So what Johnny and I just went through, it could be a little daunting for people. So they want to make sure that they're covered. And we want to make sure that you as a lay responder are covered too. In the good faith administration of naloxone, you are 100% covered by Rhode Island general law, the Good Samaritan law, and it's naloxone specific. It also provides coverage to you if you carry one of these kits and you do not administer naloxone. I always think that's super important too, because we're encouraging people to become first responder or bystander responders. So you're covered in the good faith administration, and you're also covered if you mistakenly do not provide naloxone, which I think is equally as important.
And people shouldn't be afraid of this. This isn't like some kind of a drug like heroin or something like this. This is the panacea to get people back to life. You know, it's not like you're going out and buying a drug.
Right. I think it's really important too. So the idea behind Narcan is that it is a harm reduction strategy, right? So increasing access to naloxone does not increase risky drug behavior. Some people can get a little uneasy about saying, oh, well, you know what, we're just saving people who have this addiction and they keep coming back and keep coming back. But really, again, if you start to think about what we talked about earlier and the brain disease of opioid use disorder, is that this tool is to keep people alive so that eventually, even if it's the 15th time that we have saved them with Narcan, they will get into the right program at the right time, because we know recovery is possible and we want to make sure that people stay alive so that they can get there.
Can this also be possibly a dangerous, kind of unsettling, experience for somebody who's administering the Narcan, and how sometimes do some patients respond?
Sure. So there is sometimes a misconception, and it's not necessarily a misconception, because depending on the route of administration, a reversal of opiate overdose can be a little dramatic. Some people can sit up, they do not feel well. However, withdrawal is not life-threatening, which is really important to know. So if somebody does wake up from their overdose and they're in withdrawal, it's not life-threatening. If they wake up and they're not too happy, you know what, get out of the way. That's kind of what I say. If they wake up swinging, don't fight them. Make sure you've called 911 and you've done your part to help keep this individual alive. Yeah. The likelihood of an angry withdrawal is less likely with the intranasal version than it is with the others.
So once again about the Narcan, because this is a lifesaver. Are there any logistical considerations for naloxone, and how should we store it?
Great. So Narcan does not like to be exposed to extreme hot or cold. So it really prefers room temperature. So you'd think if you get this kit, you could maybe leave it in your glove box so that if you ever run into an emergency, you would have it available, but we do not recommend that. It is not said to become dangerous when it's exposed to extreme hot or cold, but it's said to become less effective. So room temperature is where it likes to stay. So what I did with my kit that I got is I opened it up and I actually took out one of the doses, because this is a little bulky to be carrying around every day, and I understand that. So I carry the one dose with me on the street in the instance that I encounter an overdose and I can help. So I would recommend somebody do that as well. Maybe break it open and carry one around with you in the day. But again, it likes room temperature, no extreme hot or cold, and please do not leave it in your refrigerator or glove box. And there is an expiration date. So it usually is about 2 years past the time that you get it. So if you keep an eye on the expiration date as well. Again, the drug will not become dangerous after the expiration date, but it's certainly said to become less effective.
We've got pockets of this country that are just awash in these problems. And of course, we're experiencing our own problems here in Rhode Island. Facts, figures, numbers, what have you got for us as far as overdose is concerned? I know the number's going up.
So we talked about in 2016, that was Rhode Island's highest year so far, and it was 336 Rhode Islanders died of an overdose. In 2017, Rhode Island was one of only 2 states that saw a reduction in our overdose fatalities. We went down to 323 individuals dying of an overdose in Rhode Island. It's not a huge pat on the back. We're not celebrating a 4% decrease. However, it is something to look at, because again, Rhode Island and New England were one of the first areas to start to address the fentanyl epidemic in our illicit heroin supply. So we learned really quickly here in the state that we needed to implement sanctions that helped keep people alive by increasing access to naloxone and also increasing access to medicated assisted treatment. So people in recovery need treatment. So Rhode Island did really, really good in implementing medicated assisted treatment within the prison system here in Rhode Island. So people coming in with opioid use disorder were screened in the prison system, and if they had opioid use disorder, they were offered a medicated assisted treatment. The Rhode Island Department of Corrections was able to decrease overdose fatalities within the prison population by 60%.
That is absolutely
which is overwhelming.
Crazy. Isn't that great?
And there's no way that did not correlate to the 4% decrease in the overall overdose fatalities, because primarily people coming out of prison who had opioid use disorder, remember, they have a decreased tolerance to opiates. So when they were released back into the system without any treatment, they would go back to using the drug that they went into prison for that perhaps caused some of their, financial and economical issues. So they went back into that same lifestyle, and they used opiates again, and their tolerance was low, so they were at a higher risk of dying from an overdose upon their release from prison. So Rhode Island recognized that was a huge population that we needed to address. We addressed it, and we started to see a decrease in 2017.
That's great work, and we should be proud of the great work that folks in our state, police and fire, and of course in corrections too. Incredible numbers in corrections, a 60% reduction, that sort of thing. They're doing a great job. Our numbers are going down. What more do you think that we can do, or than what the state can do? I know that the governor is very much involved. She's got a task force, and she's been very much involved in this. What more can we do?
So my charge right now would be to businesses out there, to franchises that are seeing increased use within their bathrooms or perhaps in their facilities. My charge would be reach out to us. Let us come in and train your employees. Let us get Narcan behind the counter or in the bathrooms and train your employees on how to recognize an opiate overdose. Even if it's somebody in the labor field, if they're interested in getting a Narcan kit and want some medical direction, the Rhode Island Disaster Medical Assistance Team is here to help.
Well, this has been really terrific. Thank you so much for coming on the show. I know that we're going to hear a lot from our viewers about this, and we'll have you on the show again and talk about other issues.
Great, thanks, Jim.
Thank you so much.
Thank you.
This has been a terrific show. And that's it for this edition of Labor Vision. We'll see you next time.
Thank you for joining us for this edition of Labor Vision. We appreciate your input and encourage your comments. Labor Vision can be seen on this channel 3 times each week: Tuesday at 7 p.m., Thursday at 8 p.m., and Saturday at 5 p.m.